Good evening, everyone. I'm very pleased to announce again our ESSM position statement webinar, and this evening we have two marvelous speakers, Stephanie Bo from Leiden, the Netherlands, and Elisa Maseroli from Florence. They are both two of the authors of the statement, and they will give us today this webinar. But before we start, I would like to give the opportunity to our President, Carlo Bertocci, to say a few welcome words.
Thank you, Kobe, and good evening, everybody. It's really my great pleasure to join this starting moment of the webinar. And again, thank you very much to both Stephanie and Elisa. They are really a great value for our society, and so I'm quite proud to be here, Elisa, for their lecture today. I just want to spend really a few words, a couple of slides. First of all, to thanks to the people that have spent time to organize this webinar. Kobe and Giovanni, they have done a huge job in order to make this product, this scientific product, very functional and very successful. And so I think that we are, all of us, happy about these webinars that are running. And I can tell you that as a society, we have decided that this webinar will then be available. And so you will see them all recorded on our website afterwards. But it is important also to spend a little bit of time about our educational activities. And you know that we have done a lot of job in order to publish two big books, one on sexual medicine and one on clinical sexology. And these are for us our Bibles, because we think that the most important contents and acknowledgement about our activities is over there. And so you can really use them as much as you can, because they're very successful. The same as it is for the new book that is already on marketing, because we have finished to prepare it, and is a textbook on surgery. And so we cover also the part of the surgery that is very important for some of us that follow this activity. And so again, you have a lot of nice books that you can use for your acknowledgement and skills. And the last information that I want to give you is with regard of new activities. Daniela can move to the next slides, because we have already prepared an academy for surgical academy for genital surgery, and this is very important because we have changed a little bit the way to learn and to teach the surgical skills, and we have completed a very good program in order to make our young fellows as much as possible good surgeons. And so this project is ready and will be starting next year, 2021. So everybody is interested can have a look in our website and start to take some information about it. And last but not least, the videos. We have already some videos on erectile dysfunction in our website, but we are now trying to increase the number of videos, not only with some new video on surgery, but also some new videos that we are planning to prepare about some other topics. So we really believe that a good video library could be very helpful for our society, for everybody is member of it. So that's the time that I wanted to take, and so I don't want to take any more time. So thank you very much. I really want to go back to the main topic and the brilliant speakers that are ready to start. So thank you very much, everybody, to be here.
Thank you very much, Carlo. Another important person who contribute a lot to the creation of the statement and for this webinar series is our scientific chair, Giovanni Corona. So Giovanni, do you like to say a few words?
Thank you, Kobe. Thank you, Carlo. I think this is a very important topic. Elisa, Stephanie, and Linda, and all the authors involved have in some way created, have clarified a very difficult topic. The paper is already published. in Journal of Sexual Medicines. Is still receiving a lot of quotation, because I think that for sure we have created a position statement of the ESSM, but indeed we have clarified, especially with their support, a very, very difficult topic, especially as sexual medicine stakeholders, but also I'm endocrinologist. This is a very difficult topic, even among the endocrinologists. So thank again to Elisa, Stephanie, all the authors involved. Thank again to all people who already delivered their statement. It was a great success. Next week we are going to present our last statement, but a new wave of statement is ongoing, and I hope to present the statement, maybe not through the web, but in other way next year. So thanks again, and please copy and enjoy this evening presentation.
Thank you very much, Giovanni. Just before we start with these wonderful speakers, who again, thank you them so much for the contribute to the statement, to the activity, and for being available to give this webinar. For you, the audience, you can chat with each other, and you can also ask questions. There is a button called questions and answers, and you can send us questions, and our panelists will try to answer them only at the end of the presentation. So we will not do it between, because we will give them the opportunity to give the presentation. Some of the questions that started in the beginning are answered during the webinar. So at the end of the presentation, we will try to give the possibility to answer as much as possible questions. We will have also full questions, which mean that we will like to know your opinion, and you can vote on them, and we will share the results with you too. And if you want to chat with each other, there is the chat button. So I will stop sharing my screen, and I will give the opportunity to Stephanie and Elisa to teach us and keep us up to date with this wonderful statement. Thank you very much.
Okay, thank you for the introduction, and welcome to everybody. Thanks for joining us. We will give this webinar on hormonal contraception and female sexuality. And here you see the authors of the review article we made on this subject. I'm a psychologist, and Elisa is a medical doctor and specialist in endocrinology. So today we will use as the basis for this webinar the review of evidence of effects of hormonal contraceptives on female sexuality. Of course, contraceptives are widely used, and in Europe, most women using contraceptives use hormonal contraceptives, and they often use it for quite a long time in their lives. And the safety and efficacy of these hormonal contraceptives is well known. However, in general, there is little attention for the potential impact on sexual function, while this may be very important also for compliance with contraceptives. We did a review on the literature on effects of hormonal contraceptives on female sexuality. It was a narrative review, not a systematic review. We looked for literature most in Medline up to July 2018. We looked at evidence for effects on various aspects of female sexuality. We looked at effects of different types of hormonal contraceptives. We came to several conclusions which were discussed in the author group. And we also created these conclusions on level of evidence using the Oxford criteria. And according to the Oxford criteria, level 1 is the highest level of scientific evidence. And we also created the level of clinical recommendation, and level A is the highest recommendation. The outline of the webinar for today, first we will discuss the potential mechanisms of action of hormonal contraceptives on sexual function, female sexual function. We will discuss the evidence for effects on sexual desire, on orgasm, lubrication, pelvic floor and urological symptoms, partner preference, sexual and relational satisfaction, if there's enough time. And we will end with conclusions and clinical recommendations. But before we start with the discussion of the potential mechanisms of action on sexual function, we would like to ask the first question to you, to the audience. And you will be enabled to answer this question and see what your current knowledge is and see whether your knowledge maybe needs some update or refreshment. So Kobe, maybe you can introduce the first question. And will I be enabled to see the answers, Kobe? Ah, okay, thank you. Okay, well, most make a choice for A or C. Well, let's see, we will see after the explanation and discussion by Elisa, you may find out what the right answer is. So I will stop sharing my presentation and Elisa will take over.
Right, so as you may know, hormonal contraceptives can have a positive effect on sexuality. In fact, they can overcome the fear of unwanted pregnancy, and this may be good for the woman. And they also may help to resolve some troublesome gynecologic disorders, such as endometriosis, and reduce body image concerns, for example, in women with hyperandrogenism and hirsutism. However, for many years, also concerns about their negative sexual impact on sexuality have been expressed. So these are the main types of hormonal contraception. And in combined estrogen-progestin methods, both components work to suppress ovulation. These methods include combined oral contraceptives, transdermal patch, and the vaginal ring. Progestin-only contraceptives only in some cases suppress ovulation. In other cases, they work in a different way. Presumably, they thicken the cervical mucus and they change the endometrial milieu. And so this is the way they work. And they include injectable methods, progestin-only pills, implants, and the intrauterine devices containing progestin levonorgestrel. In combined estrogen-progestin methods, the estrogen part may consist of ethinyl estradiol 15 to 35 micrograms or a natural estrogen 17 beta estradiol. This is combined with a progestational agent which may be derived from testosterone, and in this case it will have an androgenic activity, or it may be derived from progesterone or spironolactone, and in this case it will have a partial anti-androgenic activity. Here you can see the physiologic fluctuation in ovarian steroids levels in cycling women. And women are exposed to dramatic fluctuations in hormonal levels. In particular, estradiol is low during the first phase, during the follicular phase. It peaks before ovulation and then goes down again, while progesterone is high in the luteinic phase, the second part of the cycle. This graph is oversimplified, but it's to show you what happens with a generic kind of combined hormonal contraceptives. As you can see, the physiologic fluctuation in hormones is completely altered. We don't have the peaks. And regarding estrogen, the red line, there is a general lower level compared to a normal cycling woman. But not only estradiol and progesterone play a role in this story, because androgens too are very important. As you can see, testosterone is at its higher level around the time of ovulation, just before. And it has been reported that not only in rats and in primates, but also in humans, sexual desire and female-initiated sexual behavior peak during the fertile phase. So it could be that this hormonal bilier during the pre-ovulatory phase somehow predispose the woman to be more receptive to sexual stimuli. But what is the mechanism by which hormonal contraceptives, combined hormonal contraceptives, reduce androgen levels? As you may know, testosterone circulates not free, but for almost 70% in women, it's bound to the SHBG, the sex hormone binding globulin, which is a protein produced by the liver, and only 1% is free to act on the peripheral tissue, so to bind to its receptor and to work on the brain, on the genital tissues, and so on. And combined hormonal contraceptives decrease androgen level because, as you already mentioned, they suppress ovulation, they suppress LH secretion, so they inhibit the androgen productions in the ovaries. But most importantly, they markedly increase the circulating levels of this protein. They make the liver produce more SHBG. And the net effect will be that the free and the bioavailable, but also the total levels of testosterone will be reduced. You can see in this graph that during the years, contraceptive has changed. In particular, the ethinyl estradiol dose contained in the pills has been reduced. And also, there has been the introduction of natural form of estrogen in pills. And this was made with the aim of reducing the risk of thrombosis and also to reduce the effect on the liver regarding the production, again, of SHBG. Because as you can see in this table, the ethinyl estradiol is 500 folds more potent than the natural estradiol in increasing SHBG. And also, when you have a higher dose of ethinyl estradiol in a pill, this will make your SHBG go much higher than the a lower dose of ethinyl estradiol. This increase in SHBG induced by the estrogen in the pill or also in the vaginal ring in your combined contraceptives can be modulated by adding a progestin with an androgenic activity or a progestin with an anti-androgenic activity. Indeed, not all progestin are the same. All progestin work on the progesterone receptor, but they also can work on the androgen receptor. And so we may have, for example, levonorgestrel, which is a typical androgenic progestin, and drospirenone or chlormazepine, which are typical anti-androgenic progestin. And so androgenic progestin will increase your SHBG less than anti-androgenic progestins. In this meta-analysis published in 2014, it has been shown that the effect of all hormonal contraceptives, combined hormonal contraceptives on total testosterone and on free testosterone is significantly to lower testosterone and to increase SHBG. However, a subgroup analysis according to the type of progestin did not show significant difference on testosterone, only on SHBG. The authors concluded that combined oral contraceptives containing second generation progestins, so androgen progestins, and the lower estrogen doses are the one with a lower impact on SHBG. So this led us to our second statement that all available combined hormonal contraceptives reduce androgen levels, regardless of the dosage and the progestin type. You may change the SHBG, but the clinical net effect does not actually change. Here you can see one of the few randomized clinical trials on the topic. In this case, women with sexual dysfunction associated to contraception were randomized to two different pills, one containing a non-androgenic progestin, the Enogest, and one containing an androgenic progestin, levonorgestrel. And all women reported an improvement in their sexual function after the switch, and the authors did not find any difference in the total FSFI questionnaire or in the total sexual distress comparing the two groups. So this study was very important because it challenged our proposed notion that pills containing androgenic progestin may be more respective of women's sexuality. Regarding non-oral options, we have the transdermal patch and the vaginal ring. They both contain ethinyl estradiol and they both contain an androgenic progestin. In theory, not using the oral route, but using the parental route with the vaginal administration or the patch should have a lower effect on the liver because we can exclude the first pass metabolism. And this is true, but when we see the data, we can notice that this conclusion is controversial. For example, in this study, the authors compared the oral and the vaginal administration of ethinyl estradiol, and the effect on SHBG was higher for the oral route, but the difference was not statistically significant. So the vaginal ring also statistically significantly increased the SHBG. And to summarize this, we can say that combined oral contraceptives, transdermal patches, and the vaginal ring all have a similar effect in increasing SHBG levels and so in reducing androgen levels. So now we can have, sorry, this is not question 1, but is question 2 for Stephanie.
And you all can vote.
Okay, thank you for showing the answers. Most people think that it will decrease sexual desire, combined contraceptives. I will continue with the question. What is the effect, or what is known about the effects of hormonal contraceptives on levels of sexual desire? Well, first of all, it's important to note that, of course, sexual desire is the effect of an interplay of physical, cognitive, emotional, and interpersonal factors. But as Elisa already explained, we also know that hormonal contraceptives have an impact on free testosterone levels. And we also know that testosterone is important for sexual motivation and for sexual desire. It can have an impact. So you may expect that androgen levels, changing androgen levels by hormonal contraception can also affect feelings of sexual desire. There are actually only 3 placebo-controlled randomized trials looking at the effects of combination pills on levels of sexual desire. There are 2 trials that compared combination pills with placebo. And there's one trial that compared a combination pill, a progestin-only pill, and placebo on levels of sexual desire or sexual interest. In these trials, sexual desire was assessed pre-pill use and after 3 to 4 months of pill use. And in these 3 trials, in each trial, small but statistically significant negative effects of combination pills on sexual interest were observed. And there was no effect observed for the progestin-only pill. So these 3 randomized controlled trials do show a negative effect of combination pills on levels of sexual desire. However, when you look at the more broad literature, and when you look at a review of 36 studies, Pastor and colleagues did a systematic review on the effects of combination pills on sexual desire. And they included prospective, retrospective, controlled and uncontrolled studies, but mainly controlled studies. And based on this, huge data set, you may say, they conclude that almost 64% of the women do not report a change in their level of sexual desire during the use of a combination pill. Actually, almost 22% reported an increase in levels of sexual desire, and almost 15% reported a decrease in sexual desire. They also concluded that in the 15 out of the 18 studies that assessed hormone levels showed a decrease in free testosterone levels. And they also found that in women with reduced free T levels, only a minority, 20%, reported also a decreased level of sexual desire. So it seems to be the case that a subgroup of women, some women, may be more sensitive to changes in testosterone levels. They also conclude, based on the data in this systematic review, that combination pills with a low dose resulted more often in reports of decreased desire compared to combination pills with higher dose. Based on this systematic review, we concluded that in the vast majority, the use of combination pills results in an increase or no change in sexual desire. However, it is interesting whether for women who do report a change, a negative change in sexual desire, it is relevant to ask whether a pill switch can help. And few studies do indicate, but these are non-randomized studies, indicate a positive effect of pill switch. However, as Elisa already described, randomized controlled trials showed that when women with sexual desire or other sexual function complaints change from pill and switch to an anti-androgenic or switch to an androgenic progestin, that they both improved in sexual functioning. So it doesn't seem to be a matter, the improvement of testosterone or androgenic activity, but it may be an expectation effect, a placebo effect. Furthermore, there are also studies that investigated whether adding of androgen next to the use of a combination pill may positively affect sexual desire levels. For example, in a recent study by Van Lunsen and colleagues, women used the combination pill but next to androgens. So they added androgens to the use of the combination pill, or women received a placebo next to the combination pill, and they did not observe an effect on desire. There was no difference between placebo or the addition of androgen, but they did see an effect on the frequency of rejection of partner initiative to sexual activity. So women who had the addition of, in the condition that women had the addition of an androgen next to the combination pill, they showed a little less frequency of rejection of partner initiative. So this is some indication that increasing androgen has a positive effect on sexual desire. Then the effect of non-oral hormonal contraceptives on sexual desire. Well, of course, there are many types of non-oral hormonal contraceptives, and there are not that many studies. I will not, for the sake of time, discuss the effects of studies that have been done, but the general picture is that there are no indications of more negative effects on sexual desire compared to the combination pill. And we conclude that studies on effects of non-oral forms of hormonal contraception are too limited in number, so precluding definite conclusions.
Okay, regarding orgasm, it has been suggested that the perceived protection from the risk of pregnancy can increase the chances of engaging in vaginal intercourse, and this may be a problem for women because less time spent on foreplay on other sexual activities different from vaginal intercourse may predispose to orgasmic disorders. Also, contraception may be used with the aim of just pleasing the partner, and this too may affect orgasmic function in women. In this large study performed on more than 1,000 women, those using hormonal contraception were more likely to report less frequent orgasms. In this prospective study, on a very small number of women, healthy women taking a pill containing ethinyl estradiol and an anti-androgenic progestin, drospirenone, a significant decrease was found in the questionnaire about sexuality, and also a reduction was found in the frequency of orgasm, not in the intensity, after 3 months of treatment. Finally, a multi-center cross-sectional study shown here enrolled users using levonorgestrel and 30 micrograms of ethinyl estradiol versus placebo for 3 months. And some domains were significantly reduced in compared to placebo. Orgasm was not, it did not change, and also the change was not was similar between the two groups. In this study, they compared copper intrauterine device with levonorgestrel containing intrauterine device, and they found a similar prevalence of orgasm problem, around 7% in the levonorgestrel and 10% in the copper. And also this prevalence was similar to that observed in the general population. According to this evidence, we may conclude that hormonal contraception induced a reduction in the frequency of orgasm, but as you can see, the level of the quality of the evidence is very low, and the levonorgestrel intrauterine device seem to not have an impact on orgasmic function. Lubrication and vulvovaginal symptoms. It has been found that combined oral contraceptives are associated with a reduction in the clitoral and labia minora volume, and also in the vascularization of this tissue, and with the reduction of vaginal lubrication. This has been attributed to the low estrogen level, because it's more pronounced in pill or in combined contraceptives containing low levels of ethylene estradiol. And so probably we are missing the beneficial effect that estrogen very well have on the epithelium, which is very well described in literature. For example, it has been found that combined pills with a low dose of ethylene estradiol, 20 micrograms or less, may be associated with morphological alterations of the mucosa of the vulva, leading to atrophy and to vulvar vestibulitis. Also, androgens have been taken in the picture. Indeed, we know that testosterone acting via the androgen receptor is necessary for the maintaining of a vaginal a functioning and normal structure in the vagina. For example, in the smooth muscle layer, it's important for the relaxation of the smooth muscle cells of the base, which is the mechanism leading to lubrication. And also it's important for the thickness of the collagen fibers in the lamina propria and the nerve fiber density. So the lack of bioavailable testosterone may contribute to decreased lubrication and vulvovaginal symptoms in women using contraceptives. So once again, we have a very strong clinical background, very strong evidence regarding the mechanism, but when we see the literature on the clinical data, it's quite controversial. For example, in this study, vaginal dryness was actually reported in women using very low estradiol dose pill compared to the vaginal ring, because we're talking about 30% in the very low group against the 2% in the vaginal ring group. However, as you may see from the table, during the use of the contraception, this prevalence decreased a lot. It was almost 8% for cycle 12 in the very low COC group. So it could be the lubrication is reduced, but we don't have, again, enough high quality data to say that. And no conclusion can be drawn on this topic. Comparing, again, pills with androgenic progestin versus pill with non-androgenic progestin is the same study that both Stephanie and me showed before, because it's one of the few RCT or the only RCT on this very topic. And lubrication was actually increased because the FSFI score showed an improvement in this parameter. And again, the difference was not present between the two groups. And this led us to our 8th statement: no difference in lubrication and vulvovaginal symptoms atrophy symptoms has been observed in combined oral contraceptives containing an anti-androgenic versus an androgenic progestin. In this study, a small prospective study, the vaginal ring was evaluated in extended cycle mode, so not usually 3 weeks for a month, but used uninterruptedly for 63 days. And then there's a very small hormone-free interval. And there was a difference for lubrication, but it was, again, an improvement in the second cycle versus baseline. Indeed, other types of hormonal contraceptions, the implant, the vaginal ring, and the intrauterine device seem to have, do not have any negative effect on these sexual domains. What about the pelvic floor, which is a very important actor in this story, and the urological symptoms? Again, both low estrogen levels and low androgen levels have been involved, for example, in lower urinary tract symptoms, dysuria, and also infections, while androgens have been reported to be to exert an anabolic effect, for example, in muscle of the pelvic floor. Let's see what is the evidence on this topic, because once again, the background is strong, but as you can see, we don't have many clinical data. This is, however, a meta-analysis, one of the few meta-analyses that we found during our research. And combining data from the two trials that you can see, the author found a statistically significant result indicating that painful bladder syndrome is associated actually with the use of combined hormonal contraception. And so this is what we stated in our 10th statement. Prior or current use may be associated with painful bladder syndrome. What about urinary incontinence? This is unclear. In a large male survey, as you can see, more than 21,000 women, a lot of women in the US, the investigators highlighted a statistically significant 27% increased odds of developing urinary incontinence compared to people not using or which had never used contraception. But in contrast with these findings in this large study, this is still a large study, Swedish, it was observed that the combined oral contraceptive use was related to a reduced risk for both stress, urge, and mixed urinary incontinence. And in the same study, the authors also evaluated the levonorgestrel releasing intrauterine device, and they found that there were no correlation with the LUTs. Therefore, it can be speculated that maybe this protective effect found in this study may be due to the estrogenic part, because in the UD, you don't have the estrogens. What about chronic pelvic pain symptoms? Again, low dose combined oral contraceptives appear to increase the risk. So those pills with a very low amount of ethylene estradiol, while normal dose pills seem to have a protective effect in some symptoms. And finally, urinary tract infections. No association has never been described with hormonal contraception. Only diaphragm and spermicidal agents have been shown to be associated with a higher risk of UTI. And again, we have to say that this evidence is not sufficient to draw definitive correlations about incontinence, pelvic floor function, and UTIs.
So finally, some data on effects of hormonal contraception on partner preference and sexual and relational satisfaction. This is quite, you may say, a younger area of research. It is known that there are fluctuations in the perception of male attractiveness across the menstrual cycle. So women prefer more masculine traits, face, and masculine voices in the fertile period. And in this period, they also dress more attractively, show more skin. So that, that suggests that hormone levels have an effect on the perception of male attractiveness. So a valid question is whether hormonal contraception affecting hormone levels have an effect on the perception of male attractiveness. There have been a few studies, and these are non-randomized studies comparing women using hormonal contraceptives and women not using hormonal contraceptives. And these studies showed that women using hormonal contraception show a weaker preference for masculine faces, and that women using hormonal contraception while they met their partners show lower partner attraction and sexual satisfaction, but higher non-sexual relationship satisfaction, and that stopping hormonal contraception during a marriage is associated with lower sexual satisfaction among wives with less attractive husbands. And finally, it has also been observed that hormonal contraception, the use of hormonal contraception in committed relationships, is associated with more frequent mate retention behaviors. These are behaviors focused on keeping your partner with you. So, for example, dressing more attractively or showing more jealousy. So these studies show that hormonal contraceptives are associated with changes in the perception of male attractiveness, and also are associated with changes in sexuality-related behaviors in longer-term relationships. But we should know that this is a young area of research. The level of evidence is very low. So these conclusions should be taken with, well, the notion that the level of evidence is low.
Can we please have the third question?
You can vote.
Okay, so in case of hormonal contraception associated poor lubrication and vulvovaginal symptoms, the majority of you answered that they would switch from hormonal to non-hormonal forms of contraception, right? That's the right choice, so I will conclude. How we show you, unfortunately, further studies are warranted before definitive conclusion can be drawn on this topic. This is a very understudied topic. This is strange due to the fact that contraceptives are worldwide used, and we have a lot of studies on some other types of adverse events, adverse effects, but not on sexuality. So there is not enough evidence to draw a clear algorithm. However, we developed a flowchart that may be useful in clinical practice to deal with these kind of potential side effects. When women counsel for contraception, it is mandatory, it is very important to perform a very careful baseline psychosexual relational assessment. So also ask about the psychological aspects, relational aspects. On a medical point of view, really you have to carefully check the medical eligibility criteria for contraceptive use, carefully check for obesity, smoke, and all reasons that may suggest you to choose a method or another, and also explain potential sexual side effects for each method, and always support a patient-centered decision. If you choose a combined form of contraception containing estrogen and progestin, you have to keep in mind that women may react very differently. As we saw, all these kinds of methods reduce free androgen levels, but the clinical impact on several aspects of sexuality, and in particular on desire, is not clear. If you are looking in particular, if you want to protect lubrication in your patient and avoid vulvovaginal symptoms, you may choose combined pill with higher ethinylestradiol doses or a vaginal ring, because in these two methods, as we saw, there is a lower incidence of this kind of symptoms. On the other hand, if you choose a progestin-only contraception, we may say that levonorgestrel intrauterine device virtually should not have sexual side effects or lower than the other types of contraception. Also, progestin implants have not been associated, for example, to vaginal symptoms, and also the copper device potentially has no sexual side effects. The follow-up should not be performed before 3 months. After 3 months, if the woman reports sexual dysfunction, you have to be very careful and try to understand if this is contraception related, because other things in her life may have changed the relation, the psychological component. So this is very important to consider every time, also at follow-up. If you decide that this dysfunction is actually related to contraception, if you are dealing with reduced lubrication, as you correctly answer, you may switch from a hormonal to a non-hormonal form of contraception, for example, the copper device. If you are using an oral contraceptive, a pill, you may want to switch to a non-oral form, for example, again, the intrauterine device containing levonorgestrel, or the ring, or the implant. Or if you want to keep your oral form of contraception, you may want to use higher doses of ethylene estradiol. If the problem is desire, again, switch to a non-hormonal form, or switch from an oral to non-oral form, or just to change. As we saw in the RCT from the Davis group, you may try to use progestin-only pill, or also whatever combined contraceptives, but different, because we may have a placebo effect, or we may have a special specific compound which is less active for this particular patient, this particular women. And then again, we have the follow-up. With this, we are concluding, and I want to thank you for your attention, and Stephanie for working with me, and of course the ESSM for inviting us. So we stop to share my screen.
Thank you so much, Stephanie and Elisa, for giving such a beautiful presentation on a subject which is quite complicated. And I'm very pleased with your one of your conclusions when you're showing the flow diagram, who said, pay attention to other components, which means that we always need to look on a biopsychosocial analysis of a problem of a patient with sexual dysfunction. And that's very nice to see. And again, I'm very pleased that we had two presenters, great presenters, which are also one psychologist and one endocrinologist, to highlight both aspects that involved with this issue. So thank you very much. Now, we have a few questions, and I will start with a comment, actually. Douglas from UK shared with us that he finds it quite common that progesterone-only pills produce vaginal dryness with very low levels of estrogens on the blood test, which I think that majority of us can confirm. Do you want to say something about that, Elisa or Giovanni?
Well, yeah, so we don't have any evidence on that. Actually, the studies on POP are really scant. But this could, if this is what you see in your clinical practice, of course, it may be. It should not be. I mean, I don't know if estrogen is to be involved in this mechanism. Could be. I don't know if you. What do you think about it, Giovanni? I think could be.
Yeah, it could be, because progestogens can act at pituitary levels by suppressing gonadotropins, so it could be. But the problem is that we have, as Elisa said, very few studies, especially an important study, an important thing to be taken account is that we need the study using mass spectrometry to measure estradiol, because the current immunoassay for evaluating estradiol is totally unreliable, especially for low doses. So for sure we need more study, but it could be, because progesterone can act at pituitary level. So absolutely it could be.
Great. Another question that arises, is there an association between vulvodynia and hormonal contraception?
Yeah, I showed a study on this topic. It seems there are all association studies on, they are case reports or very low-powered studies on a few patients, but it has been reported. And in some studies, it seems to be associated with a number of CAG repeats of the androgen receptors. This is interesting. Again, androgens may to be involved in this story, in particular in vulvodynia.
Another question, does that related probably to the chronic pelvic pain syndrome, does it mean the information on chronic pelvic pain that suffers could be treated by a normal dose COC?
They're just association studies, so no, I wouldn't say that. I mean, we should have some kind of intervention study to say that.
It was only association and
no
intervention. And the same goes for painful bladder syndrome, which is actually quite rare disease, and a lot of the painful bladder syndrome are actually chronic pelvic pain syndrome related to the pelvic floor muscles. There is another question concerning the DHEA that added to oral contraceptive. They did not help much when you add it, but what about adding transdermal testosterone? We know that the DHEA on its own is not effective on increased libido.
Yeah, so this was shown by Stephanie, so I don't remember if it was on sexual desire, but I agree with you, Elna. It could be an idea to add transdermal testosterone. About the HEA, I would like to add that we have an intravaginal formulation which has been recently approved by the FDA, also the EMA, which is actually approved for postmenopausal women with atrophy and GSM, but off-label may be used in some cases also in young women, premenopausal women taking the pill and experiencing this kind of symptoms. Actually, I find it useful.
That's important to show, but as you know, adding testosterone in premenopausal women is not approved yet, except the new one, and certainly not by the FDA. AMA approved in the past testosterone patch for postmenopausal women with low testosterone. Again, if there is something like that, that it's off-label, we don't have enough study to show it. And so we need to be a little bit careful with that. And I'm certainly, and personally, is not scientifically someone who supports the use of testosterone in female. Only when you use it, you need to do a very accurate measurement of the testosterone. Otherwise, you don't know what is going on. So keep it in mind. And question which have two aspects, the bio and the psycho. Sometimes decline of desire depend on from depression, probably one to men, that is linked to low dose of oral contraception. What do you think about that?
Sorry, is this for me again? I didn't.
For you, I think the more for you, but Stephanie maybe too.
Is the first one?
The second one, about the decline of desire that depend on the depression, which is linked.
Of course, it's important if you have a patient with low desire and depression to ask very carefully about depression, because depression can be one of a very important factor in one of the symptoms is low sexual desire. As far as I know, there is not very strong evidence for a relationship or an association between the use of hormonal contraception and depression. So I would think with patients with depressive symptoms to think about other important factors apart from the use of hormonal contraception.
Totally support. Another question, the first one, could the attraction that were related to the attraction to the partner, perception by women when stopping hormone contraceptive during a relationship by in part a result of the male's perception when their partner stopped taking hormonal contraception. Same for the retention action when continuing to take hormone contraception. A way to say you don't want children at that point can lead to subconscious ideas by the partner.
Yeah, well, I think it's completely right to think that there may be a lot of other factors that may play a role in this. So, of course, these are studies looking at an association between the use of hormonal contraception and changes in partner attraction perceived by the woman. But there may be a lot of other factors that are related to the use of hormonal contraception and changes in the relationship and in the sexual relationship that may affect partner attraction. So I agree completely that you should also think about other factors playing a role.
Yeah, certainly. Now I see one of the last questions of Willing of the Time, and this is clinical case, so it's nice to share a clinical case in such a situation. And Elga writes, I have a patient who is 42 years old and has noticed a significant reduction in lubrication capacity after being on the Levonorgestrel's AUD. Can it be due to progestin action on vaginal tissue? Can it compromise intrinsic estradiol and androgen action on vaginal tissue?
So regarding the first patient, again, it's similar to the testosterone case. I mean, I think there is a rationale to use local estrogens. Again, they're not approved, so you have to be very careful to carefully assess any bleeding or also do a careful differential diagnosis with maybe some other problems which may cause lubrication issues, for example, dermatological diseases, autoimmune diseases, or things like that. If you really feel that there's a problem of low estrogens, you may try, but again, it's off-label in a young woman. And about a 42 years old patient, it may depend on the kind of EUD, because we have 3 different doses for this EUD. Probably given the age of the patient, is the one with a higher dose. I don't know, because the one with a lower dose, it's not really, it doesn't change significantly the systemic levels. The question is about the local changes. It should change the endometrial milieu, but not the vaginal tissues. So I don't think it can directly compromise the estradiol and androgen action. I wouldn't say that.
Thank you so much, Elisa. One question about epidemiology. In Denmark, the hormonal contraceptives are declining, probably because of fear of different side effects. Is the same in the rest of Europe? I don't have data from rest of Europe. I know in the Netherlands was declining and now it's stabilizing more or less. Someone have data from all Europe to share with us?
I know that Italy is one of the countries in which is less used in general, but I don't know the trend.
Okay, so it's the same. Okay, thank you, Elisa. Thank you, Stephanie. Again, thank you everyone to being with us. I have another two slides to share with you, which I would like to share with you. So, first of all, pay attention to our activities of the ESSM. We are having the upcoming Congress that probably will be some announcement in that respect, but pay attention to all other activities that we are organizing and other webinars. I know that some of you would like very much to see the slides again, because some of the data were a lot of diagrams that you want to remember or to see again. They will be soon available on the ESSM website, and you will be able to see all the webinars there as well. So keep it in mind and go to ESSM.org to be able to see the things. Before we finalize, I want you to remember that on the 16th of June, we have a webinar about the expectation and satisfaction on penile prosthesis, implants in general. A few days later, Fabio Castiglione will present the models of nerve injury for rectal dysfunction studies. And on the 24th of June, Javier Romero from Spain and Leo Lowenstein from Israel will present the statement on energy-based devices for female genitourinary indication. So very interesting webinars. Stay tuned. Do the registration for the webinars through our website. And as last request, just before you log out, you will get a form to fill in about feedback with a few questions. So please let us know what you think about the webinars, about the contents. Give us ideas for your needs for future webinars as well. And last but not least, thank you so much for being with us and with ESSM. Have a good night or good evening or good afternoon, because I saw that our participants from all over the world, Africa, South America, North America, Europe, Asia. It's wonderful. It's pity that we cannot see each other like we are used to in a congress or in a meeting, but let's hope that soon everyone will be free to again and healthy, and that's most important. Have a good night. Thank you very much for being with us.